Hello, everyone. My name's Dr. Fergal Armstrong, and welcome to this episode of Cracking Addiction. And we have with us Dr. Daniel Pham. Hello, Dan. How are you?
Not too bad, Fergal. How are you?
I'm good. So I thought today we'd talk about dual diagnosis and in particular the particular depression, rather than saying mood disorders. Let's focus on depression. So let's talk a little bit about the definitions. I mean, how would you, as a psychiatrist, think about the diagnosis of depression and all the various other subtypes of depression that we know exist?
Yeah, I think to think about that, I really need to go back to just defining what we talk about when we talk about mood.
Yeah.
So, at the very basic term, mood is a person's emotional state, whether that's happy, sad, angry, excited.
Mm.
Um, and if you have extreme and long-lasting moods, that can be a problem, particularly if it starts to negatively affect, your work, your study, relationships, responsibilities. And if you have that persist and then be so sort of far-reaching that it starts affecting your daily life, then you may have a mood disorder.
Yeah. Yeah. Because the concept of disorder really is not just predicated on the phenomenology or the presentation, but it's also predicated on the presence of impairment or dysfunction.
Yeah,
So
absolutely.
it's
If
got
you
to
look
be
at,
bad enough to make you impaired.
yeah, and
Yeah.
absolutely. If you look at any DSM criteria for mental health disorders, they'll always have this line at the bottom that says this is causing clinically significant distress and impairment in
Mm.
so.
Yeah.
And
Yeah.
it's interesting because mood disorder, particularly depression, and anyone can identify with being sad. That's a normal human condition. But
Mm.
when does that sadness become disorder? When does it become depression? And I guess,
So,
yeah,
I mean, just going back to that point about everyone feels sad. I mean, if you look at the reactivity and the timelines of feeling sad, that can allude to a diagnosis, can it not?
yeah, absolutely. Um, I think you're sort of alluding to the idea of grief or complicated grief or adjustment disorders, and that can have sort
Mm.
of a temporal timeline. I guess
Yeah.
what separates those kind of disorders from, say, major depression, again, that's sort of the nature and severity of the symptoms and what that means. Um, so I guess going back to your original question, how do we define it? When you think about depressive disorders, there's a number of things that you can think about. So major
Mm.
depressive disorders, one. Um, persistent depressive disorders, or what we used to call dysthymia. Uh,
Hmm.
substance disorders that lead to depressive symptoms.
Hmm.
And in the recent DSM, I think they also came out with premenstrual dysphoric disorder, which is a fairly newish concept as well. And on
Yeah.
top of that, you also have depression symptoms caused by medical conditions, which is another thing that you got to keep your eyes out for.
Yeah. So there's various specifiers, but if we focus purely on major depressive disorder, how do you diagnose a major depressive disorder?
Yeah, so you need to have symptoms that are persistent
Yeah.
and cover a range of different criteria. So the
Mm.
cardinal features are having a low mood. You need to be depressed in the first place.
Yeah.
And, and most of this, again, the symptoms have to last for at least most of the time for 2 weeks. That's the sort of
Yeah.
threshold we're looking for. The other cardinal symptom would be that sort of anhedonia, the loss of interest or pleasure in life.
Hmm.
And apart from that, there are a number of other sort of symptoms you can look at. So there's suicidal thoughts or thoughts of death, that's coming with a sort of sense of hopelessness about the future, impaired concentration, just constant rumination or just impaired focus in some ways. Then you
Mm.
have some physical symptoms like sleep. So people can actually either oversleep or undersleep, so having very disrupted or poor sleep because of depression. Appetite, again, either way, you can have very reduced appetite, just not feel hungry at all, or you can be overeating. Um,
The sleep and the appetite, though, they can allude to atypical depression, can they not? So if you're overeating and you're oversleeping, and you're stuck in bed all day under the duvet and you don't want to face the world, that's different from the depression where you're losing weight and you can't sleep, or you've got early morning awakening, isn't it?
Possibly. And you like when we talk about these sort of clusters and different subtypes,
Yeah.
sometimes they're can be very, very cleanly of one. So I think we're talking about agitated depression as one subtype.
Yeah.
So the very slow sleeping all the time, we're talking more about the melancholic depression. It's
Mm.
very difficult to treat. But often, sometimes people don't really fall neatly into each category. So that's why I sort
Sure.
of have that sort of disclaimer you have
Yeah.
either way.
Yeah. Sure.
Um, and psychomotor agitation is still something we didn't cover, which probably applies to both. So that's sort of a very depressed person, often very psychomotor sort of slowed, thinking, the action is just really slow. Everything is very much an effort. Or you can have that agitation even when you're feeling depressed and just constantly on edge kind of thing.
Sure.
Um, and we've talked about the loss of pleasure and interest, anhedonia, but also amotivation, just getting out of bed. A lot of patients say, look, just
Mm.
getting out of bed and facing a day is a real chore. And they feel
Yeah.
this other feature of this inertia, this lack of energy. They feel tired all the time, despite the fact they're sleeping all the time.
Yeah.
So you need, there's about 9 key criteria, and you need about 4 or 5 of them in over 2 weeks to qualify for a diagnosis of major depressive disorder.
Yeah. I mean, I suppose if we're trying to look at those nine, we also need to think about this idea of worthlessness and guilt and low self-esteem and poor concentration. So we've got the kind of the biological criteria that the weight loss, the fatigue, psychomotor changes, sleeping. Then we got these kind of these ideations. This I feel terrible. I'm a bad person. I'm worthless. I can't do anything.
Yeah, as you
I
mentioned,
can't
guilt.
concentrate.
Guilt.
Guilt. Yeah.
I cause a lot of burden for other people around me.
Yes. Yeah.
That's a very common theme.
Yeah. I mean, thinking about suicide, which is one of the factors for the diagnosis of major depressive disorder, one of the themes, two themes that really worry me is this: when people talk about how they feel isolated, that really concerns me. But also when people talk about how they feel as if they're a burden on others. When I hear those two, it really makes me, sit up and pay attention.
Yeah, and it's important to understand that we're talking to people getting to a point where this is a very much a clinical disorder.
Mm,
Just bad thoughts that can be told. Say no, don't think that way. You don't have. You're not a burden. That kind of thing.
mm,
It really very much is a cognitive distortion, and it's part of the mental illness. They're having a state of mind which is not what they normally would be, and if treated properly, they can be reversed. We'll
mm.
talk about treatment a bit later, but again, it's not just an idea of they can just think their way out of it, which is often
Yeah,
a
yeah.
no.
Snap out of it.
Yeah, get
A
on.
lot, some of my patients are told that. Get on with it. Snap out of it. Pull yourself together.
Yeah, I think it's an important thing to sort of explain to not only patients but also family and friends and carers because it can be quite frustrating and distressing to have a loved
Mm,
one, sort of always, they seem like they're just moping around. They could
mm.
choose to be happy if they just get out of bed, kind of thing. Well, sometimes it's not that easy.
Yeah,
Sometimes it gets to the point where maybe there is something biological or deeply
yeah,
psychological going on that
yeah.
needs treatment.
So those are the criteria for major depressive disorder. But you did mention earlier on this concept of persistent depressive disorder or dysthymia.
Mm.
What's that? How do you diagnose that?
So it's largely the same criteria as depression, but it lacks some of the more severe or significant criteria, and also some of the what we call the
Mm,
neurovegetative symptoms. That's sort of the very physical symptoms, like
yeah.
the appetite. You still have, sorry, you do have still have the appetite. You still have the insomnia or hypersomnia, and you still have the low energy and poor self worth, but you don't have so much the suicidality or that sort of intense anhedonia. So
Mm,
you still feel sad, but you're not getting to the point that's severe.
yeah.
That's as severe as major
Yeah.
depression. So you used to call it
Yeah.
dyslipidemia, and you can have this persisting for a lot longer than just 2 weeks. So it can
Yeah.
be
Yeah.
the diagnosis. I think you need to have the symptoms for at least observed for at least 2 years to
2 years.
qualify. Yeah, yeah.
So you've got to feel depressed for 2 years. I mean, the untreated prognosis for a major depressive episode, my understanding of that is that it's about, it can vary between 6 to 12 months, but the diagnostic criterion for persistent depressive disorder is at least 2 years. I mean, that's awful.
I think the other way to think about that, the people who are already suffering really significant symptoms. They're two-week markers to count, that sort of persistence and pick it up. 2 years, I think, not wanting to diminish the idea and diagnosis of dysthymia, but you're really capturing the people who don't really make that sub-threshold for major depression.
Mm.
They have this low underlying grumbling. They're still low
Yeah.
mood and other things,
Yeah.
but they just crumble along and not really get affected as much as depression. So I think that's why they have that sort of 2-year mark, sort of capture that
Mm.
lower severity of things. Because
Yeah.
these people may not often be as disabled as someone with a major depressive disorder.
Yeah.
The other thing that's not covered in DSM, but sort of gets alluded to in ICD, is that idea of adjustment disorder.
Yeah.
And that's sort of, again, depressive symptoms not quite making the threshold for major depression, but
Mm.
occurring in the context of a stressor. You get bullied at work, or something happened, you have a breakup, and it just
Mm.
persists longer and longer and longer.
Yeah. Yeah. So really, I read somewhere that adjustment disorder was really a diagnosis of normality in terms of feeling sad and reacting, but that's not to take away the potential misery associated with that diagnosis.
Yeah.
But
And
it
again,
doesn't, as you see, yeah,
yeah.
doesn't meet the diagnostic thresholds.
Yeah. And to be sad after something bad happens is a very normal human reaction.
Mm.
Where one can argue it is a social cultural lens you have to see it through. When does it become something that's
Mm.
not normal? Like,
Yeah.
if you're sad that you broke up with your partner, sure. If that's still
Mm.
a case and it's affecting your concentration and it's affecting your sleep, months
Yeah.
after the fact, maybe it's to the point where you need to get some help.
Yeah. Yeah. Now we're meeting on a podcast called Cracking Addiction. So I suppose it behoves us to look at mood disorders or to look at depression through the lens of substances. So is there a diagnosis that we can look at in this context of the combination of substances and mood
No.
depression?
Well, it sort of how you say throws back to our previous sort of talk about co-occurring disorders. So you can have mood disorders that lead to drug and alcohol use. So if you're feeling
Hmm.
quite, negative about the world, having a drink helps you cope, and you develop an
Hmm.
alcohol use disorder. In the same vein, having depressant symptoms or having constant withdrawal, intoxication can lead to you developing a mood disorder in itself.
Yeah. So
So,
alcohol. Look, going back to that, alcohol use disorder can occur as a result of depression, but it too can also cause depression.
yeah, and there's a special category of substance-induced mood disorders. Um, and again, you're having the same symptoms, but there's a correlation you can draw in your history taking of the substance causing that. So in this case, yeah, alcohol leads to depression.
So in particular, I'm thinking in that context of substance-induced depressive disorder. And I suppose that could be alcohol, couldn't it? If you had an alcohol use disorder causing a depression, that could be a substance-induced
It
depressive
could be,
disorder.
and it could be any of those things as well.
Yeah,
So
yeah,
any other substance like stimulants or opioids.
yeah.
I often will explain to patients, it's not a nice ride having this up and down cycle of intoxication, withdrawal, intoxication, withdrawal.
Mm,
Withdrawals aren't much fun. There are a lot of physical symptoms, but a lot of mood symptoms that come with withdrawal,
yeah,
and that can sort of just compound on top of your other sort of stresses. Life's not that great when you're constantly nauseated, but also going through financial stress and also going through family stress from your substance use, all
yeah.
contributing to depression. And I guess that also highlights that with depression in general, our understanding of the actual cause, the etiology of depression, is actually quite limited. We don't actually know exactly what causes it because it can be quite complex. It could be a genetic thing. We know that depression can run, if you have a strong family history of depression, you're more likely to have it.
Mm,
Or it could be a psychosocial thing. So if you
mm.
grow up poor, if you grow up disadvantaged, you're more likely going to have developing depressive disorders, for example.
Yeah,
Combination.
yeah. The good old monoamine hypothesis I don't know if I'm slightly older than you. I don't know if you were taught that in medical school, but I certainly was, and that's been debunked now as an explanation for the etiology of depression.
Yeah, I was taught that. I think it's still getting taught because it's a relatively reductionistic but easily digested way of
Yeah,
understanding how
Yeah.
depression and antidepressants work. And for
Yeah.
those not so aware, monoamines sort of theory sort of implies that a, a deficiency in one of the monoamines, particularly serotonin, leads to the development of depression. And we know it's a lot more complicated than that now. Doesn't discount the fact that our antidepressants that work on serotonin, they do work. But whether that's because we boost the level of serotonin in our neurons, or is because that boost leads to development of neural pathways of reshaping of things, it's not very clear.
Yeah.
How then also does psychology, talking through stresses, how does that help with
Yeah.
depression in some ways?
Yeah, that's a really valid point, because we know that psychological therapies do help in depression. So, they certainly don't alter monoamines. I've heard about, maybe not the etiology, but I think depression can be seen through the lens of negative affective bias, where by various etiological mechanisms, you just see the world with a gray, depressive lens. And I'm led to believe that the role of antidepressants in reversing negative affective bias is very good. They really do it very quickly. But again, once you've altered that negative affective bias, it still takes a number of weeks or a number of days, in fact, just to lift the mood.
There was a game that was developed specifically for kids. I can't remember what it was called, but it was meant to help educate mental health, and it was a very, very useful way of helping to educate about depression to kids,
Hmm.
where you'd be given choices to make, and you obviously knew what was the best choice for the question being asked, but those choices were grayed out. You couldn't select them; they were there, but you couldn't actually see that, and it just sort of reflects that sort of negative cognition that you get very much shoehorned, and you can't think. Like I said before, you can't really think your way out. You're just sort of rigidly in that negative mind space, that sort of
Hmm.
hopelessness, that sort of negative self-concept in some ways.
Yeah.
One thing you also touched on was the treatments. The treatments for the depression we have now, they are very effective, but unfortunately, they often take a lot of time as well.
Yeah. What are the, I mean, I think maybe I was going to say, what are the treatments for depression? I mean, that's two or three talks in itself, isn't it? I mean, broadly and quickly, can you summarize the treatments for depression?
Absolutely. Because when we diagnose major depression, we can stratify it into mild, moderate, severe. At the
Yeah,
mild end, beyond anything you start off with, lifestyle. And I think you'll be a big proponent of this, Fergal.
absolutely. Yeah.
Lifestyle is a huge thing. Just having good hygiene, good self-care, good diet, and I mean, it is a very easy to say, but often it can be quite challenging, particularly in major depression.
Mm.
But advocating daily exercise, good diet can be a huge thing. A
Yeah.
pill
Can
won't
I
help
can I
you.
just can I just
Yeah,
interrupt with the exercise, right? So I
yeah.
read a very clever paper
Mm.
where by some very clever statistics that I could not understand, they worked out that if you exercised and burnt off 17 and a half calories per kilogram per week, that was a good antidepressant. 17 and a half calories per kilogram per week is an antidepressant.
Yeah. Imagine he gets the endorphins going, probably contributes to that as
I
well.
mean, I don't know why, but yeah, that figure stuck in my mind.
Again, we say that, and some of these things are very simple to sort of address. But also, if you're already amotivated, anhedotic, not getting out of bed because of this crippling addiction, crippling depression, getting that regular exercise could be a challenge in itself. And that's probably the role clinicians and health professionals have in trying to figure out ways we can facilitate that. So, beyond the lifestyle things, particularly for the mild end of the spectrum, we actually all advocate, less more conservative measures like psychotherapy. So psychotherapy works great in mild depression, and take your pick. There's a lot of studies around CPT, motivational interviewing, ACT therapy, so acceptance commitment. They all have their efficacy, and just whatever works for you in that sort of space. I think the key
Mm.
thing for the psychotherapist is picking someone you can actually form a good relationship with and actually
Yeah,
work
yeah,
through those issues. And then if you're going up to the more moderately severe end of the spectrum and beyond, you're talking about either choosing pharmacotherapy or psychotherapy or a combination of both. So just
yeah.
very briefly, I'm talking about pharmacotherapy. You're really talking about antidepressants. So SSRIs or SNRIs, tricyclics. They're all varying effectiveness, but you really just they're all effective in some ways, but you're really picking the one that is well tolerated. And unfortunately, you need to wait a certain amount of time for them to work. So you need to get to a good dose where you can tolerate, and then wait about 6 to 8 weeks. So that's roughly the amount of time it takes for some people to get the full effect. Some people may notice some effect a bit earlier, 2 or 4 weeks, but we normally will give 6 to 8 weeks before we declare if it's working or not. So you do a combination, or if you get to such a severe that's jeopardizing life and limb in some ways, we're talking about ECT.
Yeah. I mean, on the subject of antidepressants in depression, I mean, people ask me, well, like, will they work? Will I feel better? And there is this knee-jerk reaction to the prescription pad when a lot of clinicians are faced with someone in distress or someone who presents with a mood disorder. I think it's important to understand that the best predictor of efficacy for an antidepressant is the severity of the depression. So if you don't have severe depression, it's less likely that the antidepressant per se is going to have any significant effect. And I always bring it down to this certainly for SSRI. So the numbers needed to treat for an SSRI, I read elsewhere that it's about 7. Right? So that means that 7 people need to be treated with an SSRI for one person to get better. Now that sounds pretty awful, but you got to put it into context. So for instance, the numbers needed to treat for neuropathic pain with Lyrica is also 7. So that's not so bad. But what concerns me is the rate of side effects. The rate of side effects for SSRIs is about 2/3. So 2/3 of patients are going to have some kind of side effect on an SSRI.
And
there's a number needed to treat of 7. So you've got to put it into that context. They're not a panacea. They have to be used judiciously and appropriately. And the best predictor is the severity of the depression.
Yeah. No, totally agree with that.
Yeah. Look, on that sweet note, we're probably going to have to wrap it up. I want to thank you for your expertise, and I hope we can meet again soon, Dan.
Thank you, Fergal.
That's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.